Hi, and welcome to Policy Unpacked, a podcast by the Global Policy Network. In this series, we dive into policies shaping our world, from healthcare to sustainability to education, and we explore how those critical areas intersect to drive meaningful change. So whether you're a policymaker, practitioner, or just policy curious, we're really glad that you're here and have joined us. Let's unpack policy together. Hello listeners, I'm Stephen Riley, Deputy Regional Chief Pharmacist, NHS England, North West, and an Associate at the Global Policy Network. And I'm delighted to be hosting this series unpacking the 10-year plan. Today we're joined by Sarah Trust, a highly experienced clinical pharmacist and healthcare leader whose career has spanned specialist practice, research and national policy. It's great to have you with us, Sarah. Thank you for joining us.
Thank you.
So just really to give a bit of a flavour for our listeners and about your career really and where you've got up to. So looking back at your early years as a pharmacist, what experiences or challenges during that time really shaped the trajectory of your career in clinical pharmacy and healthcare leadership?
I started off my career working in a big London hospital and, realising that pharmacy was such an inescapable companion to medical practice in that setting. And I could see that, my input was wanted on ward rounds. And as I was training and developing, I didn't feel I really had all the skills. And at times, although I was open to learning, spending time learning than actually contributing in that setting. Then I moved down to Brighton, and that was my first job as a lead pharmacist, and I was lead for surgery. And surgery was quite a different discipline. Their need for pharmacists is a lot higher in surgery, in my experience, and they're very good at surgical procedures, but not so good medically. And that's where I suppose I came in, doing a lot of drug stops in patients who were hypovolemic, for instance, stopping antihypertensives, getting involved in a lot of deprescribing. We had a lot of patients with leg ulcers. They'd come in on massive doses of opiates and then their leg would be removed and nobody would think to reduce the opiates. So we lost a couple of patients before we all understood actually we needed to stop these things, because once the pain source is removed, the driver is also removed for respiratory rate. So, opiates become toxic quite quickly. And so that's where I got involved in deprescribing heavily. Then I moved to renal pharmacy. And of course, a lot of medications get deprescribed around kidney disease. Mm-hmm. So patients would come in, they would have their kidney problems, and then they would go home on fewer medicines invariably. And so then I got into liaising with GPs, teaching patients, helping them to understand and engage in quite complex regimes at times, and also then getting involved in opiate deprescribing in that setting, where actually they'd come in on high doses of opiates and then their kidney function wouldn't tolerate them having those anymore. Then I moved to primary care, and that's where I put all of those skills into one, really. And I just became a bit more of a deprescribing champion. And one episode sticks with me where I understood actually in that setting, people aren't so ready to do that. And I had a GP come to me and he said, I have this patient and she's in a nursing home and she's refusing now to swallow. Can you change all of her medication to liquids? And there was a list of about 8 medications to change to liquids. And I said, well, I can do that. I think the bigger question is, how many of these do we really need to have? And he looked at me like I had 2 heads. And I thought, oh, that's interesting. Actually, maybe we're not ready in this setting to be the same and as aggressive as we are in hospital, in a sense, because we have everything at our fingertips. Yeah. And I guess actually the parameters are fewer in GP surgeries. For instance, you don't have an hourly blood pressure. You're not always looking at the U's and E's. You can't, you might have not from one year to the next to see what's happening with a patient. So, that's where I've kind of brought my unique brand of therapy to this setting, really.
It's a really great career pathway there. Really good, development into different areas and bringing those skills with you as well. It's really fantastic to see. What was actually your route into pharmacy itself? So how did you find a passion for pharmacy?
Well, I worked in Boots as a sort of 16-year-old, and I worked on the counter, and I thought far more this is demanding a bit more cerebral of me than your average Saturday job. You know, I'm having to learn things about who not to give aspirin, who not to sell aspirin to, who not to give paracetamol to, who not to give ibuprofen to. And it's quite challenging, actually, as a 16, 17, 18-year-old. And I always knew that I wanted to be in healthcare, but I didn't know where I wanted to be. And my thought was that I wanted to be a physiotherapist. And then I did my A-levels, and that wasn't what I was going to be doing. So I actually, in a hurried way, looked through clearing and thought, oh, look, there's pharmacy. Let's go for that. And that was literally the barn door moment that took me into my career.
That's it.
Yeah.
Fantastic. It was great. It's great to see you starting at that initial role, and it inspired the love of learning and want to be in healthcare and help people, and to see that develop into obviously what's a clearly really strong passion as a role for you really going forward. So obviously you've given us a good overview there. So we started something hospital care, clinical practice, moved into more specialist functions, and now primary care. Was there a particular moment or role in your career when you realised you wanted to move more beyond clinical practice into broader leadership or policy work, and have you had any stumbling blocks around that area?
I found that moment is probably now, and I have been a pharmacist for 25 years, and I have quite a broad landscape of knowledge across primary care, secondary care, and then I've locumed for decades in community as well. So I feel like I've got a good view of the landscape of what being a pharmacist is, actually. And I've just done a leadership course, Chief Pharmaceutical Officer course, and having done a few leadership courses in the past, that one left its biggest mark on me. Mm-hmm. And I feel like now is the time I want to get into more leadership roles. It has proven quite difficult to get into those roles in pharmacy, being that it's quite a small, fairly buddyistic community. And so I'm looking to broaden my reach into other areas, but it's just thinking about what my next steps will be with that leadership, and where I'll find myself. I'm thinking I should probably get a coach to help me to think about that, actually.
I think that's always a positive step. I mean, we always benefit from coaches, mentors, and learning from others. That's how we support others as well. Have you got any particular advice you give to early career pharmacists?
Yeah, I mean, what I would say is, sure, earn your crust. I mean, I spend a good 10 years learning what you're doing before you start branching out into this sort of, into the leadership domain. I've probably waited too long in my career, and I think that's because, I had a lot of personal circumstances through my 20s and 30s, and it just didn't take me into this position. I think now is the time when I'm more ready to do it. I think probably looking back, if I'd done it sooner, I probably would have been further ahead. So that's really a barrier for me. But I think if you're an early career pharmacist, make sure you're understanding, don't limit yourself to one domain. And the thing that I did that I would really advocate for other people is to change your job frequently. I've met pharmacists who've been in their job for 25 years, the same role. They are a different breed to the people who move around routinely and get the experience. And one thing that I've always prided myself on is my ability to just bounce between different jobs. And it's just because I love learning something new. And so every 3-4 years, I change. And so I've got a lot of experience in a lot of differing areas now. I taught doctors how to prescribe. I became a medical tutor for a little bit of a while. I've done lots of different roles in my career, and it's made me multifaceted.
I think that's such an important thing as well, particularly as we develop the workforce of the future. We as pharmacists, an article I read recently about generalists as pharmacists. I think we are in healthcare sectors. We are really good quality generalists, and we got clear specialist skills. And you've done some specialist renal work and things of that nature. But having that really good generalist ability to be able to go into different role sets and be multifaceted is so important, something we can really excel at. I mean, with pharmacy, there's so many options you can move into, so there's a variety to support career moves, which I think is really crucial. And I know from your role in renal services, you had a responsibility for strategic planning and advising on national policy implications. How you manage to balance day-to-day clinical leadership with long-term strategic priorities?
Well, I mean, I suppose, yeah, that's the tricky thing is, what I find now is, sometimes I like to be involved in national things. For instance, I did some webinars around opiate misuse and how to get rid of opiates in primary care. But bringing me back to the day-to-day of just doing what I'm doing, seeing one patient at a time, it's not motivating me in the same way as sort of the population health. So I'm very lucky to be able to spend time actually just working up population health objectives. And that's how I keep myself satisfied with balancing, more strategic kind of things with the day-to-day role that I do. In renal, there was actually two of us, one of us who managed outpatients, one of us who managed inpatients. And so that gave us a little bit of scope to broadly talk about how we could manage renal better in the community. And we started objectives to do that when I worked in renal, and that's how I found myself in primary care. Now I do need to roll out, I do need to roll out more renal sort of, or it's my intention to roll out more renal pathways in this landscape. Yeah.
That's fantastic. And that's a nice linkage as well. I think one of the big shifts from the 10-year plan is that shift from hospital to community, and the opportunity of bringing those pathways and treating people close to home and making better use of our primary care workforce. And obviously you've made that transition to primary care pharmacy elements around the general practice support work and prescribing work. So thinking about the 10-year plan from a primary care pharmacy perspective, what would success look like by 2035?
Well, I think, pharmacists will be well embedded into the healthcare team. I think they already are. But I think we could co-opt in. We could less siloed work, definitively, and maybe even rotations across the three domains for practitioners, hospital, secondary care and primary care, so that we're all really tacitly understanding each other's roles. Because I think, quite often what I've found is, collaboration happens, and this integrated care happens just through knowing people.
Yeah.
And because I've spent 20 years of my career in a hospital, I'm able to just ring up my friend who's the anticoagulation pharmacist to give me an opinion on whether this patient with the PICC line needs to still be on enoxaparin. Those sorts of things are very, very helpful. And, collaborative care can't really happen unless we're all understanding and working together. So by 2034, I'd like to see a truly collaborative healthcare wrapping round to support patients in a way that's just in time, preventative, and keeping patients in their own homes and out of hospital for longer.
I think that's a fantastic place for us to be and to get to. So my day job, my main function roles around pharmacy integration. I think that collaborative approach is so important, and building those authentic relationships with people so we can call on colleagues, peers. I think it's really important to be able to bring in that expertise from secondary care, some specialisms into supporting primary care practices. So it's really going to be a key enabler to how we deliver and safely support our patients. It's important. And just thinking about your role in primary care pharmacy, how do you see that supporting the prevention agenda within the 10-year plan?
Well, look, I'll give you an example of something that we've done. We've got some quality improvement projects that we've had to do, largely funded by NHS England to foster collaborative working in neighbourhoods. So we've got a QI project that we're doing across the neighbourhood. And I used my clinical acumen to suggest that we look at COPD, being that I was the COPD lead in the last practice. So just as an example of this, we've got a collaboration of, hospital consultants, GP trainees, pharmacists, nurses, everybody, all involved in a COPD project to support and care for COPD patients who haven't had reviews this year. So that sort of proactive care example is really part and parcel of what is in the 10-year plan: preventative care, keeping patients out of hospital for longer, by optimizing, by just taking this moment to skill everybody up, optimize care around one specific long-term condition, and make it better. And I think that's what, something by just highlighting, hey guys, do we see what's happening in this particular setting? It's not good enough. Can we make it better? Leaning up. I'm a big advocate of lean working and leaning up transitions and pathways for patients to make them quicker, faster, and now we've got the connection with a consultant in secondary care. There'll be no harm to just ring up. Oh, hey, this is a bit tricky. Can you have a look at this patient? What should I do with this? And GPs are fostering those sort of connections. Pharmacists are fostering those connections, and they will pay dividends massively into the future.
And that's a fantastic example as well, too, showing that the optimised pathways to better improve care for patients, those outcomes you described, really supportive. And it's a great example of how we can easily, well, not easily is not the right word, but we can adapt those pathways for many therapeutic conditions and support for patients. That's a fantastic example. And you mentioned also previously is that you're really passionate about deprescribing as well. So in your view, would you think deprescribing is the new prescribing?
Yes, it absolutely is the new prescribing, because, deprescribing people, if they care for themselves, and if we can start to talk more proactively about self-care, it wraps with healthcare so dramatically. So, I'll give you an example of the patient I reviewed in clinic recently. I was about to give his third intensification of a hypertensive drug, and I said to him, I'm going to put you on a third drug. What do you think about that? Well, I don't like that, he said to me. And I said, why don't you like that? Well, I don't want to be on all these tablets. I said, you don't have to be. You know what? I looked at his weight. Lose 10 kilos, I'll stop 1. Lose 20, I'll stop 2. Lose 30, you won't be on any of these tablets. That's your choice. Yeah. And he said nobody had ever put it to him so clearly. So if we're constantly the people who are the supporters of this kind of self-care, then we can be the ones to take away medications. So my other thing that I'm thinking about doing, I've got a trainee pharmacist with me. We're going to look at all the patients on Mounjaro and those sorts of weight loss drugs, GLPs, and look at them and say who has lost significant weight and who therefore could have some drugs deprescribed. Yeah. In that setting. I reviewed a patient the other day who'd lost 30 kilos on Mounjaro. I said to them, you're not diabetic anymore. The last blood test you had, you're not diabetic anymore. I'm going to stop your metformin. And, suddenly I think the wake-up call was, oh, right, okay. I didn't even know that was, that was something that was going to be an outcome that I was expecting, which, is just an amazing thing to be able to share with patients. So, I think that's where I would say, I take students a lot and I train the next generation. And I had one stop me and say, Sarah, for a pharmacist, you don't really like medication, do you? And I was thinking, no, because there's side effects to everything that we take. That's right. Everything.
It's so important. I think it's that message we give as pharmacists. We help and support people with medication, but it's the right medication at the right dose at the right time, and sometimes that's no medication or stop medications. I mean, thinking about a wider implementation. How do you think we could maybe implement a deprescribing culture nationally, and what think maybe some of the key barriers may be to this?
Well, I think we are wedded in our ethos of a patient comes, they come and they go away with a prescription. And I feel like that is, in primary care, that is the mandate. You come with a prescription, you come with your problem, I give you a prescription, you go away happy and satisfied. Now, if I just gave you a piece of advice, that might not be as satisfactory to patients. That I consider would be a massive barrier to a deprescribing national objective. But But I also think, like, let's take my opiate deprescribing. That is a specific skill set that maybe people don't feel competent to do themselves. And I know this because a lot of GPs in my setting don't feel confident to do that. So, asking pharmacy colleagues or anybody else to get involved with that without the proper skill set is quite a barrier to doing this. The other thing I would say is you have to tacitly understand pharmacology to be able to pull things away. And so you have to be quite experienced. I think you almost have to be uber experienced to know how to do this. It can't be a junior pharmacist who goes in and says, oh, look, that is, for instance, the blood pressure is this, I can stop that. No, you have to look at all the other parameters of how old is the patient? What's their falls risk? What other medications are they on? What's their other diagnosis? Are they diabetic, for instance? Are they, do they have heart failure? What other diagnoses pay in to actually managing their blood pressure a little bit more robustly? Do you see? So it's not just an easy thing to do. Having said that, I think we could roll this out. There should be no barriers to doing this. But what has surprised me is how uncommon it is. Certainly just in my N equals 40 people that I've worked with, don't do it. So, yeah, I don't know. I think it's just bringing it up the agenda, which is going to help roll it out. And I think there shouldn't be any barriers to it.
Yeah, I think that's really important. It's a really good point you raised there about it. It's one of the things, I think it's a simple thing to do, but it's not easy to do. You need the right level of experience and confidence to do this properly and do it well. And that's the thing, some of the key things which are really important. I'm sure you're obviously fully aware of the resource challenges we're facing with medicines costs and things of that nature. And I'm sure there's a lot of focus around cost efficiencies. So how do you maintain a patient-centered approach and focus while still trying to work to get value for medicines or cost efficiencies?
Well, this one, I've actually saved 150,000 across my PCN last year. And that, like, as I sort of honestly say, I didn't have to break a sweat doing that. So what I mean when I say that is I got all the due diligence from the ICB around, they do all the working up of getting all the EPAC data and things. They tell us high cost items that we've prescribed in the last 3 months, and then we log in and we review the patients. So it might be things like, for instance, using a omeprazole liquid in children who are a certain weight and could have a 10 milligram MUPS system, which dissolves on the tongue, which is significantly less expensive than buying in a costly liquid as a special. It could be a brand switch, that we've been asked to do. Now, I don't totally do all of these because I don't think they're all clinically right. For instance, I logged in to do a venlafaxine brand switch and the patient had 6 in the past 6 years. Well, that's not appropriate to keep doing. So, but this year, Sucarto was last year Sucarto was the cheapest metformin. This year it was metformin. Well, I'm down with switching that because no clinician reads it as metformin. It doesn't get adjusted for renal dysfunction. So I will switch that back to metformin because I think that's a clinically safer thing to do. And that saves the cost. But also then taking a keen eye on, why are we using all of this vitamin B? And then going through and systematically reviewing the patients. Deprescribing vitamin B, for instance. Or we had one GP who was prescribing a multivitamin for people with PMT, and it was costing excessive amounts, like £1,000 in one surgery. And so there was 20 patients, and just systematically I worked through and I deprescribed every single one of them. Lidocaine patches cost an absolute arm and a leg with no justification for their use. Stopped those 7 patients in one surgery. That saves £5,000. So it's just stuff like that where actually, talking to the patients about you don't need to take this. Why are you putting anything, doing a structured medication review, taking time to understand why they take the medicine, what value they think they're getting out, And I find that kind of lay belief is such a fascinating thing. Why do you think you're taking this? I'm not sure why I'm taking it. Well, why are you taking it then? These kind of like conversations it opens up are brilliant. And so taking that moment to do those sorts of things, and I estimated that would save millions if every PCN was doing this in the land, we would save millions across the NHS. That we could put back into patient care. And the fact that we're that maybe we're not doing this, or it's not publicized that we're doing it, and we need to get cuter at doing that. I think we need to start shouting about what we're doing as pharmacists.
Yeah, definitely. It really shows the value of our profession, what we deliver. And I think you're right. It's some really great examples that you've given, keeping that patient at the centre, having patients, shared decision-making, presented conversations to really support and underpin that work, and make sure the clinical support is there for the work we're doing, the cost efficiencies, and shows that holistic approach to care, which is the best for everyone. And you give some really good examples of some of the collaborative working approaches that's been undertaken across your systems, and how we think things will work better in the future. Just think from an approach of working within industry and partnership. What 3 things would you need from an industry partnership for it to work well, and what makes them not work well?
Three things that we need is a rigorous upholding of the ABPI. So, if I'm going to collaboratively work with pharma, I don't expect them to stand over me with a stick or KPIs to tell me that I need to prescribe their drug. If I find that their drug is actually the best one, I will of course use it. But I don't expect to be incentivized to do that. So that's one thing that helps it work well. Again, open-mindedness. There's a lot of fear around collaborating with the industry, because somehow they're the big bad wolf, and guess what, they're not. And I think if you're liberally minded, as I am, you can see actually there's one place that has the money, and it's not the NHS. And if they can use their money to support better outcomes for my patients, why on earth would I not collaborate? So an open and exactly that, a liberal open-mindedness to seeing how the system can work more collectively. So those are the 3 things that are needed. What is not needed, I alluded to earlier, is any stick waving to say that you need to be doing something, which I don't think exists in the industry these days, to be honest. I just don't think it exists. So and I did a collaborative working agreement most recently with Novartis, and it was a cardiovascular workup. And guess what we achieved? Lots of health inequalities were addressed in that workup. For instance, I went into a very deprived GP surgery where cholesterol was clearly not managed and ignored for years. And I managed to get patients on statins. I managed to get them on Nustendi. I managed to get them on ezetimibe, and I also managed to get them on inclisiran.
Yeah.
So and that was a classic patient-centered approach.
Yeah.
Your cholesterol's out of range. Here are the options of what I can do. Which one would you like to take? There you go. Right. You'd like the injection. We'll get you prescribed for that, and we'll have that given. Very easy to be patient-centered in that setting.
Yeah. Again, it's a great example of an industry partnership where it supported their expertise, their resources, supported NHS service delivery. So when done ethically and appropriately, as you say, it can work really well. I think, which is a great example. That we need that type of partnerships in the future, I think, to make things work for us. Just thinking about in terms of how the training for the pharmacist entering primary care has changed now. I think in line with the 10-year plan, how do those changes to education and initial training support the 3 shifts in the plan?
Yeah, and I think this is the first year we're going to see, right? Certainly I've had some students this year, and I've found it outstanding, their level of knowledge. Their level of clinical knowledge has been amazing. It's brilliant. And I'm interested to see where that's going to land, how that's going to land, and what are we preparing them for? You know, do we even know? And I think in a lot of ways, I feel a bit sorry for academia. They've had to wholesale change their courses for a landscape that nobody really knows, because it's like a shifting sand at the moment. And what I've seen is they are uber prepared to, let's say, run a bay in a clinical setting, in an AMU, right? They have all the skills to put up the fluids, to, you know, resuscitate a patient. Is that going to be something to do in your everyday practice? You know, who knows? Who knows what the future holds, right? And actually, as prescribers, we should have a certain amount of ability to touch patients, to understand what it is that we're treating them with. Can we take their blood pressure? Can we listen to their chest? Can we do these kind of things? The level of what I've seen that they're capable of, or that they understand, is outstanding. And I'm just interested to see how this year it beds into practice. And I think my personal moment of view it is that they're very good for secondary care and maybe not primary care, but we'll see.
I think some really good points there. I think the key thing, as you say, it's fantastic to see the new level of clinical knowledge and the focus, and in the cross-sector arms, the training being prescribers. It's the question then is as a health system, what have we got for them to do, and how are we going to best utilise them new skills and keep them motivated, active, but we're using an appropriate and safe manner. So I think it's some really good things for us to take away then, how we think about how we do that in our practice and our system approaches. Just thinking
the other thing, just to mention on that is prescribing. You know, it's a great skill, but how many of us who have this prescribing, this brilliant prescribing ability, how many of us use it every day?
Of course.
And really, you know, if we're not using it every day, how can we teach others to use it every day?
You're right, and I think that's a really fundamental question. That as policy and leads and as system leads, and we need to really work through how we can utilise those skill sets effectively for not just the new colleagues coming up, but the colleagues who've been qualified as prescribers for some time, and also some experienced colleagues who are undertaking prescribing qualifications now as well. So you're quite right. There's an awful lot to think about there. Just thinking about your GPM role. So what inspired you to work with GPM?
I just love the ability to rub shoulders with just about anybody, which you don't get in any other setting, really. So, you know, just on the roundtable discussions, for instance, you know, leads of this, leads of that, leads of this, it's brilliant. And I love it. And, you know, so that's why I get involved. There's also a lot of passionate people that you meet at the programs. I went to one on wound management, and the passion from the people in the room was staggering. So that's why I love being part of the Global Policy Network, and also to help shape the future of you know, the healthcare system I work in.
Yeah, that's really positive. I think that's some of the things why I got involved myself. There's really positive aspects to that. What do you think makes GPN different as an organisation, as a policy organisation?
I think it's a listening. It's doing listening exceptionally well. You know, it brings collective minds together. It, you know, somehow finds the visionaries in the field and places them in places where they can extol the virtues of what they know. And I think that it gets people thinking. It's a sort of collective hive mind, if you like, where we can all learn something, take something away, and absorb something into our practice. So that's what makes it different. And given that you can interact, you know, over webinars, virtual webinars, or you can interact by actually coming up to London and you know, meeting as well. So I think that's quite a lovely group of more system to be involved in.
I definitely agree with that. And what could people expect from you in your GPM role?
Well, you can expect me to never be shy about telling you what I know. And, and bringing the passion alive in what I do, bringing the constant betterment that I have for my patients, bringing that to the network and showcasing, and also just highlighting where health inequality is just not serving patients in the proper way.
I'll be really positive. I'll be really looking forward to see how that goes, and we're actually working together in the future. And then finally, in this particular policy podcast series, we've been asking each guest to ask a question for the next guest. So last week, Uzo was asked me to ask you, what is the one thing you would change to make pharmacy more influential in primary care?
That's a tricky one, because if you're in primary care as a pharmacist at the moment, my perspective is it's a difficult place to be, because GPs are having less of a position now. They're in ours funding. It's a role erosion rather than a collaboration, and if we're not careful, we tread that gauntlet exceptionally difficultly. And so I would say that's the one thing that needs to change, is that we need to stop being seen as just pharmacists and instead be seen as the healthcare leaders that we can be. For instance, I've taken a position in a primary care setting, but I'm not just a pharmacist. I'm actually a medicines lead, and I observe myself that way. I don't have that title, but I do lead on writing policies around supporting better medicines use, and I do lead on, safer systems for working with medicines, and I do lead on, all these kind of things around opiate reduction, and so. I see myself as a medicines lead. Whether everyone else sees me like that remains to be seen. But I think it needs to be changing to see us as leaders a bit more.
I think that's so important. It's that working as a leader and being a leader without necessarily having the leader in your job title. And it's actually how we portray ourselves and what we do. And the role you do and how we deliver it is leadership, rather than being called a specific medicines lead, or it's how we deliver that function. So important. It's a really important point. And it's now a chance for you to get your own back, as it were. So next week, we're closing off the series with Amina as the host. So is there anything you'd like her to ask me about the series as a whole?
Who has been your most important and influential guest? And what have you learned from them?
That's a really good question. So I'll give that some serious thought, and I'll look forward to answering that when I have a meeting with Amina for the next podcast. So unfortunately, that's all the time we have for today, but it has been a real pleasure to talk with you today, Sarah. Before we leave the listeners, is there any last thing you'd like to add or say to the colleagues?
Let's just keep being as good as we can possibly be, and make every day your best possible day, getting it right first time for patients.
That's a fantastic message to leave us on there. That's a really positive thing to take away. It's a fantastic motivational element. So again, let's like to thank everybody for listening to Policy Unpacked. We do hope that you've enjoyed this episode and as insightful as it was engaging. And a big thank you again to Sarah for sharing her time and expertise in such a powerful way with us today in a fantastic conversation. And remember, everyone, please follow GPN on all social media, subscribe to the new podcasts each week, new episodes, and we hope you'll join us next time when I sit down with Amina to reflect on the key lessons we've uncovered through this whole series. Thank you very much for joining us.
Oh, thank you for having me. It's been a delight.